Hello and welcome, everyone. My name is Renee Garrett, and I'm your speech therapy PD podcast host for Brainstorms, Functional Neurorehab for SLPs. Before we get started, we have a few items to alert you to. Each episode is 60 minutes and will be offered for zero point 0.1 ASHA CEU. Here are the financial and non-financial disclosures. Professor Bauer Malandraki is a full-time salaried employee of Purdue University, and as a guest on this podcast, she will receive an honorarium from Speech Therapy PD. She has no relevant non-financial disclosures. My financial disclosure is that I'm the owner and founder of BrainBridge Connect, and I am also adjunct faculty at both James Madison University and Old Dominion University. And as the host of this podcast and other educational webinars on speech therapy PD, I do receive financial reimbursement. My non-financial disclosure is that I'm the secretary for the Communication Disorders Foundation of Virginia. Now, without further ado, we welcome our guest, Jaime Bauer Malandraki, who is a clinical associate professor in the Department of Speech, Language, and Hearing Sciences at Purdue University. She received her bachelor's degree from Portland State University and her master's degree from the University of Wisconsin-Madison. Her primary clinical and research interests lie in the evaluation and management of swallowing disorders across the lifespan, with a special emphasis on neurodegenerative conditions and head and neck cancer. Professor Bauer Malandraki also holds a second master's degree in instructional design and technology and has expertise in designing and implementing innovative instruction to maximize learning and engagement using holistic models of clinical education and supervision and fostering resilience and well-being for students and professionals. She teaches the graduate level course on counseling and SLP and AUD and is a passionate educator, mentor, and student advocate. Thank you so much for being here with us, Jaime.
Thank you so much for the invitation.
So we have some questions for you today. And one thing that I always like to start with is just how the counseling piece became a passion area for you, because I think that gives people background as to why you've invested a lot of time in supporting students and other professionals in this way.
Yeah, no, it's a great question. So I have been doing this role as a clinical educator for just over 10 years now. And I feel like a lot of us who get into this work, it wasn't something that I had a lot of experience in, but it was something I for one, knew I always wanted to work with students. But I think, again, like most of us, we're never quite ready for what that means, right? And sort of in practice. And so I just encountered early on in my tenure here, students having difficulty just managing the mental health of life, having difficulties in the graduate program that just seemed semester after semester to be a trend, and to be something that I felt like we weren't addressing enough, right? We weren't talking about enough or being open about enough or being aware enough about the things that we do as educators or the constructs of our programs, how that might be contributing to the stress and anxiety and the mental health challenges that the student has. Because certainly, everyone comes with their own sort of pot to deal with in life. But if we're seeing enough of a trend, I think it's always important to look inward and say, what might we be doing to contribute to that? So that sort of started early on in my work at Purdue, just as a clinical professor. And then that just sort of grew and grew semester after semester in my kind of clinical research practice.
Yeah, and you brought up some really grad school still terrifies me to this day, and I've been out for
Absolutely.
15 years.
And I think, one of the things that I think is a strength that I have, I don't know if it's a strength or it just happens to be how I am, is I have, I've never lost sight of the fact of how difficult grad school was. I think sometimes, we can get into a rut and we think, well, now I'm a professional and I do these things. But for me, whether it's because I'm a very introverted person, like I remember very well how terrifying it was to be a student clinician. Like I can close my eyes and put myself back in that place very easily. And I think that we can't lose sight of the fact that it's challenging, right? And that challenge, we learn and we grow from it, but it doesn't mean that we shouldn't empathize with people who are going through that at the same time.
Yeah, yeah. And I think you kind of already started the conversation for this first question, but we talked about why mental health supports are so essential in graduate education and clinical practice for SLPs. And I think you just touched on that right now, but can you kind of elaborate on those mental health supports and why we need to be incorporating them in our work with graduate clinicians, whether that's on campus or off campus, because a lot of people are mentoring off
Yes.
campus
Yeah.
and then moving, or graduating class into their CF. And
Yeah.
it is really important. So,
Yeah, no, definitely. So I think it helps to, when you engage in supervision or education, to really think about your work with that student as part of an educational enterprise, right? All the things that we do, all the ways that we talk to them, email with them, all that communication is part of that enterprise. And we have a responsibility to be thinking about what our impact is. And so I think when we think about the stressors of graduate school, right? So in any point in life, any major transition point, there's going to be sort of personal upheaval, right? So these are students leaving undergraduate or returning to school after kind of being in the workforce, and they're entering this new challenge, right? So that in and of itself is stressful, right? And lots of people move from across the country or they quit their job to do this. There's financial implications, right? All of those things are stressful and it's meaningful by itself. And then we add in the fact that a clinical graduate program is fundamentally different than an undergraduate program, right? You are now having to learn something on Monday and apply it in clinic on Tuesday and have someone watching you through the monitor, right? To tell you, making notes about what you did wrong. And then you're having to give feedback to, patients and families and caregivers. And you're doing all that while you don't really know what you know yet, right? And so there's a level of stress that comes with that process that I think we can't overlook, right? And I think that, this is a bigger discussion than now, but I think, we're seeing changes even from when I started 10 years ago to now in terms of students coming in with more mental health issues. And why is that,
yes,
right? So there's always, there's the stressors of graduate school itself, right? The academic performance, the rigor, the clinical practice, but then there's the burden of life that comes with it. Again, transition points, academic rigor, and then just your baseline mental health issues. And so I think we have to be mindful of there's a lot of things that students are juggling, whatever level they're at, whether they're a first semester student or they're in their externship or they're in their CF, right? It's still a transition point. It's a different transition point, but it's still a transition point. And so I think we have to be thinking about how do we create an environment that is supportive and welcoming for students so they can optimally learn and grow, right? I mean, stress and tension and conflict, those things make us better. They help us learn, but we can still create an environment where it's a little less stressful, where it's a little less tense, where there's also empathy and understanding for, hey, I know this was a difficult week, etc., right? And then give them the feedback that they need. I think we can lean into the fact that it was hard for us. I don't know anyone who grad school was a breeze for, right? And no matter, even if they were, the extroverted person who these things are, I think it's difficult for each of one of us. And I think we have to be thinking about how we how we can lean into our experiences to support students, right? That they can have a model of that it's difficult. And so it's just super important, I think, when we think about educating students, we're also thinking about setting them up to be caring supervisors in the future, right? So it's not just
right.
about here and now as a student, right? It's how do we think, how are they going to be best positioned to give the support that maybe we weren't given, right? When they're supervising someone. So we do that by modeling, right? We have to model the behavior that we want students to sort of pay forward. And then, and we'll get into this, I'm sure more, clinical work is hard. And if we overlook that fact when we're working with students and we just power through and we sign their hours and we give them feedback on how well they implemented this protocol and we don't talk about, hey, that session looked really challenging. I didn't expect this person to cry. How are you feeling about that? If we don't lean into the emotional side of clinical work and that emotional labor, and then we're just, powering these students through, we're not setting them up to be successful clinicians, right? They can, do you know, the checklist of how to be a clinician, right? How to do these things. Here's my evaluation. How do I interpret my findings? How do I, implement a treatment plan? But if they're not able to deal with the emotional rigors of clinical work, right? Then they're gonna be more likely to burn out. They're gonna be more likely to want to transition out of the field, or they're gonna switch, constantly switch locations, right? No, I'm unhappy in home health. Nope, I want to go to a SNF. Nope, I want to go here. Some of those things are normal and that's part of, how you navigate the profession. But I think a lot of times we're not setting people up with enough sort of honesty around some of the difficulties of doing clinical work. And I think that starts with the graduate level. Like we have to have students, enter this space with sort of clear eyes about this is amazing work that you're going to do. It's, it's fulfilling, it's hard work,
Mhm.
it's good work, right? But it's also challenging work, right? And we want to make sure
Yeah,
that if we support students, we're also then supporting them as professionals. And I think sometimes we get people who say, well, gosh, student mental health, not my job, right? That's not really my thing to think about, but it is, right? It's your job as a person, as a human who should care about other people, right? We're not talking about giving therapy to students. We're talking about being caring and empathetic and
right.
creating structures that are supportive. That's different than being we're trying to, therapize our students, right? We're not trying to talk about that, but we have to make sure that they see the value in having these hard conversations, right? And they can be introspective, and then they're going to be, again, a better future supervisor and a better clinician, period, right? So we have to do that work. It's essential to me.
Well, and I think, what you're not, and you touched on this too, what we're not prepared for when we go into the field is sometimes it can be heartbreaking.
Yeah.
When I work with adults, so there's a lot of times where, I might have a patient who passed away, or maybe they had like an involvement of their stroke. Maybe they had a TBI and now they had some sort of infection and now
Hmm.
they're back on the vent. I mean, there's all kinds of things that can happen. And we're not really mentally health
Not at
prepared
all.
for that.
Yeah.
And a great example, and I know people get tired of talking about it, but a great example is the pandemic, because
Yeah.
as someone who worked in acute care during the pandemic, it definitely changed me. But we also had this break kind of breakdown of students weren't allowed to come to the hospital during that
Hmm.
time. They were doing clinical things virtually, which was a whole different thing. I
Yeah.
don't know that that's ever been done, and I'm glad we could, but it also left some gaps
Yeah,
for
I think
them.
so.
And we're seeing that in early career professionals, like you mentioned with burnout. But I'm still seeing it with my undergraduate students who primarily did high school virtually, and
Sure.
then the
Yeah.
graduate students who did undergrad virtually, and
Yeah.
they have a lot of anxiety, they have a lot of burnout from learning virtually, they have all kinds of other stuff. And oddly enough, in the last 2 years, I've had more students that had like major life tragedies than I probably have ever. And it's the weirdest thing to me, because it's like it's not like someone's grandma was old and she passed. It's like I had a student whose father got murdered. I had another student who her dad had a really like surprising illness that wound him up in the hospital. It was all these things that sort of have happened the last couple of years that seems seems to be trending up. And maybe it's that the students are a little bit more vocal about it. So I don't know if there's
Sure.
a component of that, or if
Yeah.
it's just it's becoming more commonplace
Yeah.
for those mental health issues to arise, but then also these big major life things like you mentioned.
Yeah.
A lot of these students have left their parents' home for the first
Yeah.
time.
First time. Yeah.
And they might be living in California and they're from New York or
Yeah.
whatever it is. And that's
And nothing is ever what you think it's going to be. So even if you go across country to your grad program and you're so excited and you've got your assistantship and everything's lined up and you've got the perfect department, like it's never going to be exactly what you imagined, and it's always going to be emotionally fraught in some way. And so I think sometimes, it's when people get stuck in a rut of sort of doing education and supervision in a certain way, that it becomes too easy to sort of overlook those things. Or like, well, everyone has a difficult time. Well, yeah, but it doesn't mean it's that person's difficult time, or it's not the same for each person, right? I think we have to lean into the fact that people are individuals and they have individual experiences. And I just kind of want to go back to what you said before about, the rigors of clinical work. And so one of the things, I give this example in my counseling class, and obviously I go into way more detail than I will here. But to your point, we're not prepared for this, right? So we're not prepared for that, patients dying. And so I started my CF, and I went back to school later in life. So I was kind of a second career-ish person. So I was probably
same.
30, I think, when I graduated. And so I
Yeah.
was, a little more, world, like I've lived in the world, I've lived overseas, I've done lots of things. I feel like I was pretty capable on my own 2 feet. And I started my CF, and you pick up someone's caseload from a sniff. It's my first week. I don't really know what I'm doing. And it's literally my first or second patient of my first week on the job. And I go to see this patient who'd been on caseload, and I'm trying to wake him up. And he's not waking up. And I try to wake him up. And so I go through this, I'm sort of going through the list in my head, and I'm kind of getting sweatier and sweatier, and I'm starting to panic. And then finally, his arm falls out of the bed, and obviously he's passed away. And I had been blessed at that point in my life to have never seen a dead person, never known someone who died, never been to a funeral. So this was not even something I could draw on personal experience from, right? It was sort of
Right.
like, oh my goodness. And all I'm thinking in the very back of my head is like, nobody prepared me for this. Like nobody ever said, oh, by the way, you probably will, encounter lots of death and dying. You might find people dead in their room. You might, to your point, have someone that you see on a Friday who's no longer there on a Monday, right? And so I
Yeah.
think, I don't think anyone intentionally left that out. We have a huge scope of practice. We get new standards every year, right? So, I don't think it's anyone's fault, but there are things that I think from a practice perspective, we have to be more earnest about with students.
Yeah, and I think it even thinking about counseling, and you and I talked about this a little bit. So many SLPs hear the word counseling and they're like, "Oh, we can't." But there's actually some really good courses, and I took one early on in my career that for counseling for SLPs because it should be part of what we're doing not only with our patients as well. Because again, they get these heavy diagnoses. Their caregiver, may or may not stick around. I've had patients who had a stroke whose spouse wasn't able to be the caregiver, just decided they didn't want to be a part of it, and
Yeah.
they wound up splitting up. So that part happens too. But when we're thinking about those basic counseling principles, I think that's where people have this disconnect because they're like, "Oh, we're not counselors. What do you mean by mental health or basic counseling?" And I don't think
Mhm.
they don't know where to start with it. So is that
Yeah.
something you can elaborate on?
Yeah. So, what I will always say, and I think this is true for working with students or working with patients and families, is that when we think about, again, the emotional side of clinical work, not just the difficulty, but just the being able to have those conversations with patients and caregivers, feeling comfortable, right? Because most people who are afraid of counseling are afraid of the what ifs, right? They're afraid of but what if they tell me these things? And they
Yeah.
might because they're people and we can't control that, right? To me, that's the beautiful part of clinical work. I think that's why I have always loved counseling because you get to navigate things that you don't expect. But I think for when we think about how to do the work of counseling and how to start talking about mental health and well-being from a clinical perspective, I think it has to start first and foremost with, again, that earnest self-reflection. Like, am I in a good place to be able to do this work? Right? Because I think, one of the things that I tell my students all the time in the counseling classes, you know, patients know, but they will, right? If you are
Pick up on it.
not honest in those interactions, if they can't tell that you care, right? Whatever the question is, right? They're not going to feel comfortable sharing with you. And so I think, first of all, we have to think about, am I in a good place, right? So we know that 1 in 5 adults has some degree of mental illness, from mild, minimal to severe, right? And so that includes all of us, like every one of us who practices clinically. And so I think we have to think about how ready we are to really lean into that, right? First. And so, whether that's what biases do we have towards patients, right? If we have gendered bias, we have to be honest about, if I'm going to have hard conversations, am I ready for that response? Am I going to be able to be there 100% for them, regardless of what those things are that I may have, those preconceived notions or those fears or those my own mental health challenges? Am I going to be
Yeah.
able to
It's your
shelve
own trauma.
those, right,
Mm-hmm.
to deal with this person and not shut down, not be withdrawn, not flinch, right? Because again, patients will know if you're not honest. And so I think that's the first step for thinking about, I think demystifying whether counseling is part of our domain at all, right? Is to think about if we're ready for it. And then I think we have to start with thinking about making sure that we understand in the different areas that we work in. So whether that's stroke or head and neck cancer or Parkinson's, like what do we know about the prevalence of mental health disorders in those areas, right? So I think the more we know about, again, ourselves, and then, gosh, we know that, I'm making this number up, 40% of stroke patients have, higher risk of anxiety, right? Somewhere like that, but I don't want to be specific, right? Or we know that between 15 and 35% of head and neck cancer patients will have anxiety and depression, right? Okay, so let's think about why that is. So the more we know, and if we say, gosh, then we see these signs in our patients and their families, maybe, there is a co-occurrence, right? There is that intersectionality between CSD disorders, right, and mental health. And so we have to acknowledge those overlap. And then I think we start with, learning our patients, learning about our patients, right? So I think,
Mm-hmm.
again, when we think about counseling and talking about mental health, it doesn't have to be this sort of rote thing that we do. Well, that means I'm going to do CBT with my clients, right? And there's a space for that. We know in some of the aphasia work, there's some of that's being done, and that's great, right? It doesn't have to be that way. It can also just be you know, tell me what's going on and let them tell their story, right? Let them feel safe to hear that. And then you hear, gosh, I'm hearing lots of, you're thinking this sort of internally, right? I'm hearing that this person seems withdrawn. Maybe
Mm-hmm.
they're, or they're telling me, about some of these fears or things that are keeping them from enjoying their life, right? They're not able to participate in these ways. Not only does it give you therapeutic inroads to think about, well, what might we want to do and help them get there, but it helps you to understand what the burden is of the disease for them, right? And so I think when we think about basic counseling, I think first of all, it's really getting to know your patient. And there's lots of ways to do this, conversationally, certainly. There's also ways to do this sort of more diagnostically, right? I mean, there's tons of patient-reported outcome measures, surveys, caregiver surveys, patient surveys to figure out what is the impact of this disorder on the patient. That includes resilience scales, well-being scales, right? Caregiver burden scales, things that will show you sort of, okay, to quantify the impact of this disease that you're working on with the patient. Okay, the more you know it's a problem, the more you know you have something to deal with, right? That it is within your scope of practice. So I think, again, obviously on a day-to-day basis, it's, empathetic listening and those kinds of things. But I think I don't want people to get too bogged down in, well, let me go to my counseling technique 101 book and do this. I think it starts with realizing that this is an area, you know, that is 1000% in our scope of practice. And I think if we break down that sort of intersectionality of these disorders and what that mental health impact is, that's our space to sort of lean in. But we got to be honest about our own ability to do that. And then we have to be thinking about, again, the impact on the patient and what areas we can sort of investigate further how to have these conversations as they're relevant to their specific life, right? So there's a great lab out of MGH, Ariadne, I'm going to say that wrong, but she does the Serious Illness Conversation Guide, the What Matters to Me workbook. So there are nice guides that clinicians can use to sort of frame those conversations with patients, to really find out what's meaningful to them, find out what their fears are, right? Sometimes that's enough of a discussion to kind of have someone feel comfortable with you. But there are those guides out there that kind of help give you a framework to have those sort of counseling related conversations around someone's well-being.
Well, and there's two things I kind of wanted to circle back to. One is, and this is more of like just a comment. I know that as many times as I taught stroke education to patients, my first job, we had a whole stroke education group, and that was for the patients, but also for the family members. And I can't tell you, even in that space, how many times that was the first time anyone had ever addressed, and not just from me, but we had a great neuropsychologist
Mhm.
I worked with, and we had an OT that I worked with who we all did the class together. But a lot of those patients would say, this is the first time anyone's mentioned the word depression. I had
Yeah.
no idea that this could be tied to my stroke or
Yeah.
my TBI or
Hmm.
whatever. And it's continued on through different, I worked in acute care for a long time. It continued on there. No one ever mentioned
Hmm.
depression. And they were so grateful to have that acknowledgement, but then also to have the piece of, your brain has changed in response to what happened to it when
Hmm.
you had the stroke. And when you say that, they're like, it's like the light bulbs go off, and then the
Yeah.
family's like, what? Why did
Yeah.
no one tell us this? And
Yeah.
so it is a really important component of what we do.
I mean,
And
we're bad at that in general, right? Medically, Western medicine, we're terrible at that, right? And making that connection between the mind and body. So I don't want people to feel bad that if this is not part of their practice, because we've been indoctrinated to really have this sort of mind-body divide. But
hmm
obviously once you do this work and you observe patients and families, gosh, this is real, right? Or patients, we talk about stages of grief, right? We all have different ways that we grieve whatever it is, right? Like whether that's our ability to eat and drink or our ability to, speak or the impact on a loved one for these different areas, right? And so it we all navigate these sort of spaces differently. And it just becomes, I think, really important that we think about just how it's going to look differently and that we can't disassociate, the mental health component from like, we think about aphasia, right? This is not my area, but if you can't communicate, right?
hmm
You're going to be anxious and nervous and depressed and withdrawn, right? Possibly, right?
Right.
But if you're nervous and depressed and withdrawn, you may not want to communicate. So there's this very, sort of cyclical interaction between who we are as people, how we manifest that to the world, how we interact with other people that is fundamentally disrupted when we change who we are, right? I think, one of the reasons that one of my areas is head and neck cancer. And it's an area that I love working with because I think people, you know, are sort of able to articulate, I think, meaning that they don't have the communication disorder part of it in the same way that we might with stroke, but just the challenges of change, right? Like
Hmm.
if I have a hemiglossectomy, I am, fundamentally a different person than I was before. Something is missing. It's tangible. I can talk about, I can think about that, right? Versus, someone may have different, a greater difficulty, I think, articulating that difference with different disorders, right? They may not have the sort of metacognition capability anymore to have that discussion. And I just think it's thinking about communication disorders and mental health is just, it's so integrated, right?
Yeah.
Yeah.
Well, I think the other piece I wanted to circle back to was that when you mentioned, are you prepared for a patient to cry? One of my patients did cry when I was in grad school, and I cried too because she broke my heart. It broke my
Yeah.
heart. And my supervisor, not my clinical supervisor, but it was another person that was watching the session, pulled me into the office and said, "You never cry in front of a patient. You never let them see you
Old
break." And
school,
I'm like,
old school. Yeah.
yeah, I was like, but I'm not broken, but I
Yeah.
wanted them to know I
Yeah.
felt deeply what
Yeah.
you shared.
Yeah.
And I think that's fine because we have moved
Absolutely.
away from that. And when you work with someone with head and neck cancer or
Yeah.
progressive neurological stuff like I do, Parkinson's
Yeah.
patients,
They're
same
seeing
thing. A lot of
themselves.
yeah,
Yeah.
a lot of depression there, a lot of anxiety in a lot of those
Yeah.
patients. Same, kind of across the spectrum. I've seen it in different disorders, and it's not really, to me, it's not fair to tell a student that they shouldn't, that they're developing rapport,
Yeah.
they're developing this safe space, like you mentioned,
Yeah.
where, our treatment spaces often are in a room where we're the ones in there and we're with
Mhm.
the patient and maybe family or maybe whoever the caregiver may be, because sometimes that's not family. But you do have this like more intimate setting where it's closed off. You don't have hopefully a ton of distraction, but it's a safer space for them to just come in and kind of like cathartic vomit
Yeah.
everywhere. They're the way that they're feeling.
Yeah.
We've provided that. So if,
Yeah.
like
And
you
I
said,
think if they do that, right, then I think you should take it as a sign that you've created a space where they feel welcome, right?
yeah,
If someone's
yeah,
going to cry in front of you or someone tells you something that you did not expect, it probably is a sign that you made them feel comfortable enough to do that, right? So
yeah,
that's when you should feel good about yourself and not pull back. Like,
yeah. And I think that kind of leads us into we talked a little bit about the mental health challenges graduate students face quite frequently, but how do we sort of get in the space where we're changing the mindset of those people who maybe are a little bit more old school to help them understand that the students' needs have changed? Because I've seen it in some programs where people have been in the role for, as whatever their role is, whether it's professor, director, or both,
mhm.
for 30 plus years. And so they're kind of in this automatic pilot mode in some
Yeah.
ways. So how do we go about changing that mindset or maybe getting just a little glimmer in there to help
Yeah.
them
I mean, I get,
understand?
no, it's a great question. And I think that, my answers for most things always go back to sort of what's the data, right? So I think for people who might be reluctant or reticent to sort of acknowledge that A, there's enough of a problem that's different, right? That, give them the data on the impact of mental health, in students. And we know that even before COVID times, we were seeing an increase in anxiety and depression among graduate students. And we know that since COVID, that's even increased further, right? And so there's also demographic differences in how anxiety and depression show up in graduate students. Unsurprisingly, our neurodiverse, transgender individuals, Black and Latinx have higher rates of, increased anxiety and depression than our white, students. And so and there are data, large scale studies that show this. And so I think that can be an inroad to say, well, look, it is a problem, right? It's not just, people feeling like it's different, right? And so I think, again, acknowledging that it is a data-driven problem, and then talking about, again, the implications not only on the student in the here and now and how important it is for them and their well-being, but what are the implications for professionals, right? So I think if we want to make programmatic change, it matters how you talk about it, right? And it matters the impact institutionally. I think, well, yes, we want to help the students here and now, but we also want to help the profession and the program, right? And so if we want to have good, healthy clinicians, we have to have good, healthy students, right?
Yeah, I
And so it
call that
makes
future
that
you.
the whole circle come back, around. And then I think we think about, I think you ask students, right? You have to ask them how they feel, right? And I think it all starts with, I think, being open about how things are challenging, right? I think having a conversation with students in the beginning of the semester when they're incoming students, right? This is what I do with our new graduate students is talk about how, you know, this is going to be hard, right? And we can get through it together and you're going to get through it together. And there are things that are different than undergrad and graduate school. We kind of map out these differences. But I think if you don't know what you're getting into and you think it's just going to be this great time, then but I think we all go in with ambitions, right? We go in with hopes like, oh my God, I'm so excited. I got into this program. I'm going to learn so much. And that's fantastic. And we want you to hold on to that sort of, you know, that excitement. But we also want to be honest about it's going to be real hard, but we're going to get through it together, right? So I think it starts with creating a culture where people on our end have those conversations and you put it out there, right? Because I think if we just sort of wait and see, right? We just wait and we're quiet and we say, well, if they come to me, I'll be accepting, right? We're not creating an environment where someone wants to come to you, right? So I think
Exactly.
we as sort of the people in charge have to open that door to that conversation. It's the same with patients, right? We can't expect them to tell us that they're depressed and sad and that they're having these, you know, terrible thoughts, right? We have to sort of look for those signs. We have to talk about it. You know, we have to mention anxiety and depression as a consequence of stroke, and then they'll go, "Oh my gosh, light bulb moment," right? To your point earlier. We do the same thing with students. We talk about how, you know, we see increased rates of stress and anxiety and depression in graduate students, and here's why. But here's what we're going to do institutionally to kind of make sure that we can address that, right? So as individual instructors, educators, you know, be clear and transparent about your, you know, your timelines, your rules, you know, like what are those things? Be open, have things documented so that we're not having a student, you know, juggle 25 different deadlines in their mind, right? So like there are things that we can do structurally, but also just empathetically to make a situation for students where they're more likely to be honest about if there is a struggle and they're more likely to ask for help when they need it,
Mhm.
right? Beforehand versus after, right? Making those mistakes or doing, you know, whatever, being late on this or whatever it is. If you've created an environment where they feel free to talk about it, then you can usually avert more things than have to fix them afterwards. And I'll give an example, which is that I think I still hold the distinction, at least amongst my peers. I am the only person, it did happen once this year for the first time in 10 years, but it was by like 30 minutes. I've never gotten something late from a student. I've never once gotten a late soap note. Once this year it happened, but it was like, you know, with 30 minutes late and it was fully apologetic. But it's not because I have a 24-hour deadline for things, right? So it's not about I've made my deadline 2 weeks and everyone can meet that, right? So you can have standards, but you can also that are rigorous and challenging, but you can
Yeah.
also have empathy and compassion. And those two can work really well together, which is how you sort of live that experience for students.
Yeah, this last couple semesters of undergraduate, I teach a clinical observations and technical writing class, and it's the writing intensive for the major, but it's a university requirement. So the grade scale is set a little higher for them
Mhm.
to pass. And so I always go in and say on day one, we go through the syllabus and I say, hey, this class is different. I would expect that you come in, maybe you're a great writer, but we're taught to write creatively. We're
Yeah.
not taught to write technically. And it's a
Mhm.
learned skill. And if you go into this class knowing that and hoping that you're going to see this progression, because that's what we expect in your writing skills, then it should be become a little bit more automatic because you are starting to formulate what you're going to do for a soap note in
Mhm.
the clinic. And I say it every semester. And the first time they do a soap note, they come in and they're like, "Oh my God, this is so bad." And I'm like, no, you got like the class average was 11 out of 15. That's
Yeah.
not bad. That means you have some things to work on. And I
Yeah.
always say, you're here to learn.
Yeah.
You're here to learn. You
Yeah.
shouldn't know all this stuff
Yeah.
yet. You're here to learn. And I can't tell you how many times I say it. And then I always say, I tell them on day one, the number one thing you're going to hear me say and that you're going to get feedback on is use simple past tense. If
Yeah.
you have more than one verb as that simple past tense, and they're all like, no. And the end of the semester, they're always like, oh gosh, I'm still not using the simple past tense. So I told him I'm going to get a t-shirt that says use simple past tense, and I'm just
That's
going to
fun.
start wearing it to class. And I think when I started approaching it that way, I do also ask a lot, how are you doing? How's your other course load? I'm also finding a lot of the undergrads that are seniors, for the most part in this class, work full time
Yeah.
or at least work 3/4 of the time, and they're carrying a full caseload
Yeah.
of, the end of their
Yeah.
400 level courses, so they're a little
Yeah.
bit more challenging. And so I'll ask them a lot, how are you feeling? I know this lecture was a little bit of a challenge. We covered a lot of
Mhm.
material. You doing okay? Because I'm like my classes in the afternoon, and some of them have to go to work after, or some
Yeah.
of them have been at work and they're trying to like stay
Yeah.
awake.
Yeah.
They're coffeeed up,
Yeah. Yeah. Yeah.
The first time I started, like the first part of the semester when I start doing that, sometimes people will come up to me afterwards and say, "You're the first person that's ever asked how we were feeling
Yeah.
collectively." And I'm like,
Yeah.
"Are you serious?"
Yeah.
But
Yeah.
I think again, you go back to what your own experience was and how you want these students to be when they get into the field, because some of them aren't going into
Yeah.
CSD. They're going, well, some of them are going to go on to grad school for that. Some are going to audiology. A lot of them are going on to nursing,
Oh, sure.
or some other
I
type of
mean, other
medical.
super important empathy, like,
Yeah.
it just is
So
nice
this,
when people mean, and stop and ask questions. But I think we get that a lot too, that we're all so busy, right? As academics, we're super busy and the students are busy and there's lots of running around and it's easy just to go to the next thing, but it means the world to students I mean, stop and truly mean it. I mean, you can't just ask and not mean it, right? And then again,
yeah.
so, just to ask the question, how are you doing? Gosh, you see someone and they don't look right, right? They look a little withdrawn, they look a little more pensive. Something seems
Hmm.
different, right? So the more you get to know your students on the front end, the more you can read those signs, just like with our patients, right? And when you see something that doesn't seem right, ask. And maybe it's nothing, right? Maybe they're just thinking about something, but you open the door for someone to feel safe and understood if you just stop and say, "Hey, are you doing okay?" Right?
Hmm.
Whether that's collectively as a course or to the student, it makes the world of difference to people, right? And whether you do that in the classroom, there's lots of ways. And I think that one of the things we have to acknowledge is that not all students feel comfortable responding to those questions in the same way, right? And students never
Right.
have an obligation to tell you anything, right? No matter how safe of a space you create, right? People have agency over their own lives, like just like patients do and students do, and they don't have to share anything with you. But I think we have an obligation to do what we can in our words and actions to make sure that, like, I'm not just asking you today how you are, like, you have to conduct yourself in a way that shows them that you care every day in everything that you do, right?
Hmm.
And so it makes a huge difference for students.
Yeah, and I have asked the question before, and I'll just sometimes do this or this, and
Mhm.
some of them will do this. I'm
Yeah,
okay. And then
yeah,
sometimes afterwards they'll email me and say, I didn't really want to say in
hmm,
class, but I had someone this past semester who had like a really traumatic breakup with their significant other that they had been with for a while.
yeah,
She's a returning student, and it really impacted, and she's a great student. She's a very
yeah,
good writer coming into the course. And for her to come forth and say, I miss turning this in because this thing happened over the
yeah,
weekend, is there any way you'll still accept it?
yeah.
And again, it's got to be case by case, because I know everybody that's taught in academia, you've had one student who killed the same grandma 3 or 4 times in a semester
Sure.
or over a
Yeah,
year, and
yeah,
you know that because you know
yeah,
the quality. There's other things going on, but when you have someone who will, maybe they can't share it face to face, but they feel like they can tell you via
yeah,
email, because there's less pressure. If
yeah,
they start crying or they get emotional about it, they don't have to see your reaction and
yeah,
absorb any maybe trauma that you brought into the same space
yeah,
for something that happened to you prior.
yeah,
So that's another really good avenue of having that, because it's like a second open door policy, really, to have that communication that's on their terms
yeah,
and not
absolutely.
face to face.
Yeah, absolutely.
Yeah. So what are some ways we can recognize these signs of emotional distress? We've talked about caregivers, we've talked about students, we've talked about creating that safe space, but I think creating the safe space, I think we've done a great job covering, but just recognizing the signs, because if if we're not naturally empathetic, because there are people who just are
Hmm.
not, they
Yeah,
don't necessarily pick up on subtle signs,
yeah,
or what I would consider more like an overt sign, because everybody's different, your personality is different, your past experience is different, your shared experience is different.
mhm.
So how can we recognize those signs of emotional distress that may not be someone walks into the room and bursts into tears or something along those lines? Are there other things that we can be watching out for?
Yeah, and I think, a lot of them look similar, whether it's students, caregivers, patients, right? So we're looking for those signs that is someone, maybe chronically late or hypervigilantly early, right? Do they seem more withdrawn than they usually are? Are they, if it's a caregiver or that kind of thing, are they overly involved in their spouse's life, right? Same thing for students. Are they, again, hypervigilant about due dates and doing things when maybe before they weren't that way, right? Or, you know, is someone more irritable than before? Was someone more apathetic than before, right? Is someone losing weight? Is someone gaining weight? Is some like there are lots of those things again that can look just like anxiety and depression, and they might be an exacerbation of mental health challenges. They might be signs of caregiver stress and caregiver burnout. I mean, they look very similar in those kinds of ways, but I think it's the observation of those things that makes the difference, right? And so does someone seem different? And again, if we're talking about students, I think again, if you get to know them on the front end, it helps. Now, not everyone wants to be known in that same way, and that's fine, right? We can't push for that. But anyone who does this enough, at least it works with people, can see if someone is a little more withdrawn, or maybe the quality of their work has changed, right? Or if we're talking
Yeah.
about caregivers now, they're less involved than they used to be. And so I think we have to be keenly aware of all those sort of kind of extra linguistic sort of features that, someone might be presenting with, and sort of watch for those. You don't necessarily want to make a comment the first thing that you see, but do you see a trend in these things, right? Is someone, are they, late, they have a bad week? Okay, but what if it's a persistent to the next week? Well, then I think now it's time to maybe ask the question, right? So there's lots of things. And again, to your point, people come in, especially as students, with so much more on their plate, maybe than they had to when I was a student or generations before, right? I mean, life is more expensive, this is more expensive. We're getting, people coming back with families. And we can't, we have to see them as whole people, as individuals, right? And not just as, student A and student B. And everyone's going to have a different path to walk, right? And we have to be mindful and looking at that kind of stuff.
Yeah, no, and I was just thinking I had a student, not this past spring, but the spring a year prior, who just stopped coming to class. And I worked with her advisor, and we reached out multiple times and really didn't get anywhere until it was like midsummer. Class has long been over, and it was just it was like pulling teeth to try to get, and not like we were trying to get an answer about why you didn't come to class, but like, do you want to
Are
finish?
you okay? Do you need anything? Or what can
Yeah,
we
because
do
I
to,
can
yeah,
I can give you an incomplete, and then you can retake, and
yeah,
we'll replace that with your grade. But like, do you want to do you were in the class enough to have the grasp of the material? Do you want to turn
yeah,
these assignments in? And just lots of options. And again, that whole no response thing from the student, it was really a really challenging thing. And she wound up actually coming back this spring and passed the class. So I was glad we worked with her, but it was very taxing on both of us as
yeah,
being in that space, and we're trying to be
yeah,
accommodating, but yet we're not getting that back end of thank you, because I tend to start my emails when they come from students with like thank you for reaching out, or I
mhm,
know that was hard to share, thank you for sharing
sure,
that
yeah,
with me, kind of thing, because I think it helps the students to know that again you care, you've
mhm,
acknowledged that this was difficult for them to share.
yeah, yeah,
But this particular student never really did share, which is again fine, own
mhm,
agency, but it was just challenging because we were all like pulling for her to just come on, do
yeah,
it,
yeah,
come back, we'll help you.
yeah.
And so finally it all worked out. But man, it was challenging, three
Yeah, and
semesters for one
always a
semester.
different for me at the graduate level because we have, smaller cohorts and we're very entrenched in their life. So when I say, spend time to get to know them, it's obviously easier for me because I spend time with students all day, every day. But again, I do think it matters. And, to your point about sort of, acknowledging that things are difficult and that they may not want to share. And, I think one of the things, especially for graduate students, and if you are someone who supervises off-campus externships, CF, that kind of thing, I think always rely on your school coordinator, right, for those difficult things. I mean, I think you will get students and we may know a little bit more about that student and maybe we knew before that they were having struggles and they got a little bit better, right? So we weren't worried about them, but maybe they're at their externship and they're having a little bit more trouble with deadlines than they had in the program. But I think always make sure, especially if you're on an off-site supervision, that you talk to the school coordinators to again get a better sense of how that student is and get that frame of mind about kind of put yourself in that educator frame of mind, like what more do I need to know about the student? Because I think it'll make a big difference in your supervision versus if you think that they're just kind of there to supervise and see your patients, right? I think especially for offsite supervisors, it's important to think about, again, it's the whole clinician development. It's not just the skills, right?
Yeah. Yeah, there's a I'm not a big, I mean, I post things on social media, but there's someone that I know that works in a skilled nursing facility who does a lot of, I mean, it really is kind of like advocacy work because she
Yeah.
posts a lot about you're a student. You're not here to take over my caseload and know everything. You're here to learn.
Yeah.
You're here to, I'm just paraphrasing, but she puts up a lot of stuff about you're here to gain confidence. That's another one that
Yes.
I think
Yeah.
uh,
Yes.
maybe was missing in the past from some clinical externships that colleagues of mine had, where
Yeah.
they weren't being empowered or gaining confidence or having someone who truly mentored them. They were just saying, well,
Yeah.
you did that wrong. Or
Yes.
that's not the technique I would have used. Or
Yeah.
that assessment wasn't, you didn't do that exactly right. And it's
Yeah.
like, that's
And there's so
feedback.
many ways to give that same kind of nugget of feedback
Yes.
that's
Yes.
constructive and supportive versus,
Yeah.
sort of tearing someone down.
Yeah, and you talked about that earlier. You said, you feel like you had a challenge with this uh, patient. Do you want to talk it through? The assessment was maybe it was a little too long for what the patient was able to tolerate. Let's talk about that and what
Yeah.
other options maybe can we use, or even not even. I say that with questions because my on-campus clinical supervisor had this sort of, I mean, no other way to say it. She had a reputation for kind of being hard on students.
Yeah.
I didn't find that to be true, but I'm like you, was a second career
Yeah.
graduate student. And so for me, I found it helpful because she would always ask me a question that would lead me to critically think and try to find the
Hmm.
correct answer. So even
Yeah.
if I didn't get it right, she would ask me a follow-up question to
Yeah.
try to
To
help lead
guide you there, right? Yeah.
to get the answer because she knew based on her years of experience that if she did that, I was more likely to retain it if I
Yeah.
came up with it and was able to integrate information and critically think it through than it would be if she just gave me the answer.
Yeah.
And I think
Yeah.
that really, for me, that made such a difference because it helped me not only learn, but it did help build confidence. And it for some people it did not, and I guess it's not a one size fits all.
Yeah.
But like some of the things that I'd hear the people in the clinic talking about were like, "Oh, my mom didn't do my laundry this weekend, and I have to go home and do laundry." And I'm like, "Come, come
Like,
on now.
yeah, first world
That's not,
problems, right?
yeah, that's not relevant to what we're talking about right now.
Yeah.
Like,
Yeah.
we have students who have food insecurity at home. We have
Yeah.
students who don't live in safe spaces. You have all this other, that's big life stuff to me.
Yeah.
Mom, not
Absolutely.
doing your laundry, maybe not so much because
Yeah.
you're grown and you should maybe know how to do
But I
that.
think, to your point earlier, you mentioned, kind of giving them space to feel like they can mess up and learn. And I think, one of the things I always say to students is, because, this is not their externship. This is not their CF. I'm on campus clinic or off campus in town, but still in a, first year, second year. And I always tell them, this is the chance to make those mistakes, right? There's nothing you can, I'm in there 100% of the time, right? Medicare clients, like I'm in there all the time, no matter what. So there's nothing you can't say that I can't unsay if you do it wrong, right? There's nothing you can do that I can't fix. Like this is the chance, this is the time for you to take a chance on yourself, right? To say, gosh, we learned something in class on Monday, and this patient's asking me this question. I think I know the answer. I want you to try that. And my job then as the educator is to, and I will tell them this all the time, which is that I will never throw you under the bus, right? There will almost always be something good and true in what you said. And my job then is to frame that, to pull that out and say, hey, like so and so said X, Y, and Z, and then I'll add to it, right? I'll kind
Mhm.
of correct it without sort of correcting it, right? But that's how you show empathy. That's how they learn. But if they have to feel comfortable taking that chance. And so I always tell the students, like, it's my job to show you every day that we work together that you can trust me to be that person. I'll tell you it, first of all, that you can, right? And I think I have that reputation, but it's also my responsibility every day to make sure that I demonstrate to you that I'm not going to throw you under the bus. I'm not going to call you out in front of patients. Like there's none of that's ever going to happen with me, right? But you will make mistakes for sure. I'm not going to protect you. You will. You'll say the wrong thing. Like I do it. I make mistakes every day, right? And
All
that's just
human.
true in
Yeah.
life, right? They feel different now because I'm not afraid of making mistakes, right? But I'm 45 and, I don't really care anymore, right? But when you're 22, 23, every mistake, especially in a new domain, it feels more impactful, right? And then you
Mhm.
you get a huge pile of mistakes in your life, and then they're not as scary each time you encounter them, right? But in the clinical space, it's very scary, right? So we have a job, and we think about the issue of confidence, to your point. We can't expect students to just get confident, right? We have to then create an environment where they can feel empowered, right? To take a chance. They're not going to feel empowered to take chances on themselves if you've created an environment where everything you give is negative feedback, right? Or everything that they do, for everything they do right, there's 10 things they did wrong, right? So we have an obligation to sort of build up their confidence through that belief in them, right? And we can still ask hard questions. We can, have high expectations. We can do all those things, but you pair it with belief, like true, like full-throated belief in their ability to do things, they will all rise to the top. And that's 100% my experience. Like if you truly believe in their ability to do it and you set high expectations, everyone will raise to that challenge. And I think that's why I've never got, other than that once last year, something late in 10 years. And it's not because, my area is, it's easy or it's this or what, I think it's because they know you believe in them and they wanna do right by that, right?
Yeah.
They want to do their best.
I can remember too, people talking about in clinic, like the dreaded knock on the door, because we had a video officer. So our clinical supervisors would often,
pre-video days, right? I know.
yeah, they would often be in their office, and they were live watching us on video in their office, and you hear the on the door, and everybody would be like, "Oh no, so and so came into my session," and I was like, I had one time where my clinical supervisor came into the session, and I was like, "Oh, thank God she rescued me," because
right, you're gonna get students on
all
both
done.
sides, right? You're gonna get the students who doesn't want you to come in, and then you're gonna get those people who are like, tugging on your ear, like doing everything, and they're like, "Come on, like, why aren't you coming in?" Looking at the camera. Yeah.
Yeah, no, I had one I'm not I love children
Yeah.
that I birthed, but peds is not my jam. I like
Yes. No, I'm
kids.
with you.
Like
Yeah.
it's not my thing. And most of our on-campus experience for the most part was pediatrics. And I had one little girl that was just, she's a little wild, like a little wild child.
Yeah.
And there's nothing wrong with that. But like at the same time, when you're a student, even though I was also a parent, it was like, I have no idea what to do with this kid. So when I heard the knock, 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 I was like, oh, thank gosh. She's here to save the day, because
Yeah.
I have no clue. I have no clue what to do with this kid anymore, and I'm ready to like crawl under the
And
table and
it's
take.
hard, like for those of us like myself who has to be in the room with students and patients, like, I can't be outside watching. I think it's always that like, okay, I'm gonna let them go, like I'm gonna let them keep talking and see where this goes. But then you also want to like, you have an obligation to the patient and the student to make sure that, everyone is taken care of. And so it's sort of knowing when to sort of, interject and sort of take the conversation another way, or like, so it's a skill for sure to be like, when do I knock on the door? Or when do I, how much rope do I give them, right? To kind of figure this out
Yeah,
themselves versus knowing when like they're in a state of panic, I can see it, right? They need support. Right now, they don't need me to wait. Like, waiting's not going to help, right? They need me to come in and say something, right? So I think we have to figure out what that looks like for different students, right?
yeah. Well, I think it goes hand in hand with the empathetic listening and also active listening. Most of us who, not like you said, you're an introvert. I'm not. I'm definitely an extrovert. But most people who get into this profession do enjoy conversation and
Yeah.
communication. They like to talk. And so that is a
And they like
learned
people,
skill.
right?
Yeah,
Yeah.
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 And that active listening and that empathetic listening is a learned skill. We don't come out of uh, the gate in graduate school going, or even into the profession going, okay, yes, I'm just going to sit here and listen. It's
Yeah.
like when you're working with a patient with aphasia the first time, and you've learned in your coursework, the best thing you can do is wait, give them extra time. And you're sitting there and it's like the last minute on the treadmill. It's
Mhm.
400 years later.
Yeah. Yeah.
You're trying not to talk because you want to give the patient
Yeah.
the chance. And then you're just like, oh my God, this is taking forever. Oh my God. Oh my
Yeah.
gosh. And it's really been probably like maybe 30 seconds, if
Yeah.
that, but
Yeah.
it feels like an eternity.
Yeah.
And I think it's the same with students when you're,
It's exactly the same, and I tell them all the time. I said, I know, for you, it feels like, and again, I lean into my experience as a student and knowing how stressful it was, right? You're interviewing the patient and their family, and you forget the next question, and all of a sudden it's like, wah, wah, wah. You can't really hear anything. You're getting all sweaty and you're all flustered, and it feels like time is going like passing and passing, and it's been like 2 seconds, right? So I think it helps to tell them that. Like, it might feel this way, you know, if it felt this way, that's perfectly normal, right? That's sort of how I would feel, right? So I think being able to sort of empathize, but also describe, like, you know, you might have this experience, right? And most people will be like, oh my God, that's, you know, that's how it feels. I'm like, but that's just normal, you know? And so my advice to students is always, especially if you're, you know, whether it's the emotional side of things, like I don't know what to say, or there's the silence, or I asked a question and I'm waiting for the answer and I know it's going to be emotional, like, you know, in that time where things are quiet, I think that's, you know, when we don't do ourselves a service, right? It's easy to think about like, oh my God, what did I do? What did I say? What, like we get all twisted up inside our own heads. And my advice is always just focus on the patient, right? It's not about you. It is not
Right.
about you. It's not about you. It's not about your reaction to what's happening. It's not about whether you're, you know, in this moment, you have someone across from you who needs you, right? And that's it. So I think as someone who is a nervous clinician as a student, right? And I work with a lot of students who are nervous clinicians, like I think it's much easier if you, because most of us are caring people, right? That's why we're doing this. We have a sort of deep sense of care for other people in the world. We want to do this. I think if we can shift that focus from this internal anxiety around, oh my God, what am I doing? I'm so nervous. I'm screwing up. I'm saying the wrong thing. Funnel it, focus it. This person across from you, this person needs me. It's not about me. Just put
Hmm.
all your energy there. Everything else falls away. I mean, it's a practice. You have to think about it, right? You have to start doing
Yeah.
that. But I think in the moments where I was getting stuck when I was younger, that was the thing that got me over the edge to be like, okay, well, it's not about you, Jamie. Like, who cares? Like, who cares if you're nervous? Like, buck up, right? You have to do this, right? You have to do this for this person. And I think
Yeah.
when we just like, you know, we're more caring and compassionate with our friends and ourselves, right? If you can take yourself outside of that, kind of look from above about what's going on in that moment, you wouldn't be worried about you. You'd be worried about that person, right?
Yeah.
So it's
Yeah.
just a mental exercise, but it makes a big difference in thinking about how you manage the in the moment stress of doing clinical work, especially for students to be like, okay, it's normal to feel stress. Like it'd be super weird. Like, you know, even if I'm trying to be the most unassuming supervisor, right? I'm sitting there, I'm not scary, you know, it's still you have an 85-year-old patient with Parkinson's who's getting worse and worse, right? Right? He's having now
Yeah.
some significant cognitive independence issues. His spouse of 60 years is next to him and she's crying and she's overwhelmed, right? However you feel in that moment as the student clinician, right? It's not a scintilla of how they feel, right? So it's not
Yeah.
about you, right? And I think it's never to minimize the stress you feel, but in that moment, who needs it more, right? Someone else. So I think it
Yeah.
just helps to think about it in that way.
Yeah.
When you're guiding students, right? To think about it like it's perfectly normal to be stressed, right? To be anxious, to be unsure. I don't know how they're going to respond, right? But in this moment, these people need you and this kind of conversation. Kind of
Yeah.
raises the game a little bit. And most people will, you know, meet that bar.
Yeah. Well, and I think, kind of just we're moving towards wrapping up, but thinking about how fostering mental health awareness does improve those therapeutic outcomes for both patients and caregivers. And I know you talked about patient reported outcome measures earlier. I was actually reading a study this morning and I think it was out of Japan. They were using and I'm going to say it incorrectly. I know I am, but it was basically a diary for the caregiver, and they had some prompts and things like that but the point is they did the data, and they had the data driven, and they did it as a single not a single controlled randomized study. And so the data did show that people that also were able to have that more awareness of their own mental health and their responses to the caregiver role, but were able to also document it,
Yeah.
made a huge difference for them and how they felt about their caregiving experience. Because I think we hear a lot hear about, like you said too, the negatives of caregiving and a lot of the negative focus, but there are positives too.
Yes.
So I'm
Yeah.
I'm trying to make sure that when I'm talking about caregiving on a bigger stage, that I'm including the both sides of the coin and not
Yeah.
just the negative stuff, because
Yeah.
I don't think it makes people feel good to go, oh well, yeah, I don't want to be a caregiver now because you made it sound like crap.
Yeah.
That sounds really
Yeah,
really
and I
not
think to the extent
fun.
that it sounds like crap, it's the extent that we don't acknowledge it, right? I think that when we continue to, as a profession, sort of again dissociate the mind body sort of connection in sort of in general, but when we just yeah, we can't just talk about the negative parts of caregiving because we talk about it as burden, right? But it's just a consequence, right? These are consequences of caring. And if we know what they are, then we can know how to deal with them, right? So if you're,
Hmm.
if we're, it's the same with our work, right? We working with patients, working with families is fantastic. It's rewarding, it's meaningful. But if we don't acknowledge the fact that it can be traumatic and stressful and can create, again, that compassion fatigue, that moral injury, all these things, right? Working in healthcare and education is difficult in this day and age, right? There are lots of bureaucratic things going on. There's lots of systemic inequities to navigate. That in and of itself is emotionally and psychological draining. It doesn't take away from how good the work is, right? From how important what we're doing is, but it also, we can't minimize those things by pretending they don't exist and thinking that it's just rosy. And the same is true for caregiving, right? I mean, there's always sort of the good and the bad, but the more open we are about what those sort of negative things are, the more we can deal with them and go, okay, yes, working in healthcare is fraught. There's challenges, there's these things, but what can I do then to make sure that I'm doing what I can to balance those things and to not let those negative things kind of outweigh for me the positives. And everyone's going to have a different sense of what their own positive and negative are, right? I don't. Every workplace is different and has certain challenges, and what's good for one is not good for someone else. So there's always that we want to be mindful of that. But sometimes I think it can be easy to have a disproportional view of the negative things, right? There's lots of things in our field about, social media, ASHA, this, like there's lots of things to be mad about, right? But there's lots of good too, right? And I think
Yeah.
it's never at the expense of the other that we should have those conversations, but we should just be honest, right? We should be honest about what some of those challenges are. And if we're honest and if we have been doing that self-reflection to understand kind of where we're at with things, right? It's very easy to get overwhelmed by things if we're not well within ourselves. If we don't have a sense of sort of equilibrium, it's going to be easier to be overwhelmed by this, to get burnt out, for all of those sort of negative things, to want to switch jobs, want to do this kind of stuff, right? So we have to make sure that we're doing enough inward looking to make sure that, okay, well, I'm I'm not really feeling that well and balanced. Maybe I need to do a little bit of that first, right? And then see, maybe I won't react so much to this, or maybe I will, right? But it helps to be clear about it, right? Some things are worth
Yeah.
being mad about if you're in a good
Yeah.
state, right?
Yeah. And so,
So
yeah, and some aren't. Some are just kind of
yeah,
water under the
and
bridge.
sometimes when the world is stressful, and when we're living on the end of our threshold all the time, it can be hard to know which things are worth our energy, right?
Yeah.
So the more time we can spend to make sure that, as students, as professionals, as educators, that we are balanced enough to do this work, this emotional work, the better we are going to be able to have a healthy response to whatever those stressors are, right? And sometimes that
Yeah.
response is, oh, I need to pull back a little bit, right?
Yeah.
Or I need to make sure I stop working on the weekend so that I can have a better balance, right? Or,
Yeah.
you know what? I've been feeling stressed out. I've done this look, and for me right now, okay, let me pull back and do. I want to work in the schools and have summers off. It's better for my family, right? Whatever that is, like. But I think when we're in a better space, we can have that. We can have a better broad view.
Well, Jamie, just thank you so much for coming on. And even though you're an introvert, you just did
It's
fantastic.
very funny. So there's a
That's
couple
amazing.
topics, and I think the first one is dogs, and the second is like sort of mental health that I will freely talk about sort of in any space. But on the inside, I'm a little like, oh my God. So
No, it was great, and I appreciate the techniques and the tools and things that you were specific about because I think it's helpful for us as a profession to have those and be talking about it and making change in having these conversations. So I just appreciate you being willing to come on and talk about
yeah, no,
this.
well, thanks for the invitation. And I know I'm
And no, thank you so much. We look forward to seeing you again.
right. Thank you.